Hello, everybody. Welcome back to the podcast. Today we have another fantastic conversation for you. Please help me welcome Dr. Bryan Treacy. For those of you that are not aware of his incredible work, which by the end of this podcast you will be, Dr. Bryan's journey began with over 3 decades of dedicated service as an OBGYN, specializing in women's health with extensive experience in hysterectomy, tubal ligation, all that sort of stuff that we all have a lot of questions about. We're going to get deep into that today. But on his journey, especially in mainstream medicine, Dr. Treacy recognized that there were some limitations to what he could do in traditional medicine. So that's where he transitioned a bit more into holistic health and merging his knowledge and experience with his scientific knowledge and his newfound broader understanding of wellness. So this is going to be a fantastic conversation. Dr. Treacy, thank you for joining us. How are you
Thanks.
today?
I'm good. Thanks for having me.
Yeah, this is going to be like, I can't explain to you how powerful this conversation is going to be. You said you've been to Calgary, but around here, I work with a lot of women, well, across Canada, but hysterectomy is so prevalent. So that's kind of going to be the focus today. But before we get into that, you have a wonderful background or story. Could you share a little bit with us before we go on?
How far back you want me to go?
Where you decided that conventional medicine wasn't working.
Oh, that was 2007.
Yeah.
I did the traditional deal. Uh, I went, if you go back in time, I decided I wanted to be a doctor when I was 8. And I think everybody around me, because nobody in my family had even gone to college, they kind of thought it was a pie in the sky dream.
Hmm.
Until I actually did it. And then everybody's like, oh, he was serious when he was 8 years old that he wanted to be a doctor. So I went to the University of Missouri, Columbia, which is a very well respected medical school. It's, I think, ranked 19th in the US when I graduated. And then I did a residency in OBGYN in Omaha, Nebraska, and was going to be a full-time infertility doctor, and I was going to learn how to do in vitro fertilization, and I did not match in that fellowship. Um, so I decided that was the universe telling me that's not what I was supposed to do. And then I practiced, pretty traditional uh, women's health with a big focus on perimenopause and menopause. So I started out wanting to deliver all the babies in the US, and that was the least of what I did. I became a surgical gynecologist and basically a hormone expert.
Hmm.
So I was treating women in their 40s with hormones and perimenopause back 35 years ago, and everybody thought I was an idiot and a moron, all my colleagues. And I said, well, that's fine. What you don't know is that they come to me because their hormones are all out of whack and we just don't tell you what we're doing.
Hmm.
So I send them back for their pap smears and all that stuff.
Yeah.
So I wound up being fairly well known as the hormone doctor. And then when you're a GYN doctor, most women see you as a primary care physician. I don't know if that's true in Canada, but
I think so because we don't get enough care from our actual doctors that if we have access to a specialist, we're going to ask them all the questions and for all
yeah.
the help we can.
Well, so yeah, I mean, what am I a specialist? Yes, I was a specialist, but really I was a primary care doctor for women because I was the only doctor they saw most of the time.
Hmm.
And then the other thing that made me realize I've got to keep up on this stuff is if someone is pregnant, a woman's pregnant, there is no doctor that wants to see them because of the liability. They don't want to make any decisions or do anything while somebody's pregnant if something happens and they go, well, I was fine until that guy gave me this prescription and everything went south. So I wound up managing like neurologic disorders and stuff in pregnancy. And I had a patient with multiple sclerosis that I diagnosed. Um, and I couldn't get her in. She was like 8 weeks when I figured it out. And I couldn't get her in to see a neurologist until like 10 months later. And I go, well, she'll be done being pregnant.
Mm.
So I had to stay up with a lot of primary care issues and chronic this and chronic that until I realized 20 years into it, so 17 years out of residency and 21 years out of med school, that everything I was doing was basically being a pharmaceutical vending machine for managing symptoms, and nobody was actually healing.
Hmm.
Okay, so if you're pregnant and I deliver you, that's healing.
You're not
If
pregnant anymore. Yeah.
you're not pregnant, if you have a surgical problem like endometriosis and I do surgical intervention, that's you're not healing, but you're helping.
Mm.
And a lot of times, what we did, like I talked to one of my students this week. When I teach my students, all if the women, they tell me all their GYN history in class. I don't know why, but she had a benign cystic teratoma, so a dermoid cyst, when she was, I don't know, 26 years old. And so someone removed that. And I said, so see, you were healed from a benign cystic teratoma. But does anybody get healed from high blood pressure? Do they get healed from type 2 diabetes? Do they get healed from this and that and the other thing? Certain things you can't fix without pharmaceuticals. But what I figured out is you can fix a lot of stuff that's chronic that I was taught, like type 2 diabetes. I was taught it is a chronic and debilitating disease that cannot be cured, and patients will be on medications for the rest of their life.
Hmm.
And when I when I realized in 2006, 7, that seemed stupid to me, I got out my physiology textbook and my biochemistry textbook and reread them and realized, oh, everything I needed to know to help people heal is in this biochemistry and physiology textbook.
Hmm.
So if you get things back to the way they work, it's called homeostasis.
Yeah.
If you get people back to homeostasis, all that stuff goes away. Your
Hmm.
body knows how to heal itself. It just can't, especially if it's on some synthetic pharmaceutical thing that has overtaken the physiologic mechanisms of the body and is suppressing those.
Hmm.
So if you get out of the way and you optimize the biochemistry and the physiology of a person, they actually get better. And
Hmm.
it doesn't take long. It takes 6 months maybe for most people. So I started reversing type 2 diabetes 20 some years ago, about 20 years ago, when even today I have doctors on social media that argue with me and say it's genetic, you can't fix it. And I'm like, well, get out of my, why are you getting in the way of people that are actually healing type 2 diabetes and telling them that it can't be done when we're doing it? I've been
Hmm.
doing it for 20 years.
Yeah.
And so now that has become kind of a thing, people talking about reversing insulin resistance and type 2 diabetes. It can be done.
Oh
And
yeah.
you're seeing people do it all over the country, all over the world, really. So that's kind of, so I wrote a protocol that I call the Shining Protocol. And here's what I do. So I wrote it based on rereading my physiology and biochemistry. And I thought, okay, if I apply these principles to everybody, they'll get better. So the Shining Protocol is sleep optimization, number one,
Hmm.
hormone harmony or hormone optimization, which is where I live. My students, I just said it this week, hormones make the world turn on its axis. If you get the hormones right, you're 90% of the way to health.
Hmm.
I've said that for years, all the way back 35 years ago. First I is immune modulation. N is nutrition. I is inflammation reduction. The basis of most chronic disease is inflammation. N is natural approaches to health when possible, not always possible, but when.
Hmm.
And G is get moving, my fancy way of saying exercise of some kind. Because
Hmm.
people hate the word exercise, but if I tell them to move, just move.
Hmm. Yeah.
See what I mean? So I applied that and I started doing that to everybody over 40. And lo and behold, they felt like they did when they were in their early 30s, late 20s.
Hmm.
So if you do all that, 6 months later, they've lost weight, they've come off meds, they've got energy, vitality, their sex drive comes back. All this cool stuff happens because we've gotten out of the way of the homeostatic mechanism of the body to heal itself.
Hmm. Yeah.
So, so you start doing that in traditional medicine and you get in trouble because my approach to thyroid is not synthroid. See what I mean?
Yeah, bold. You're very bold.
Yeah. So if you don't, if you know, if you get, if some regulatory board gets a hold of you and says, "Oh, you're not doing what everybody else does," I would say, "Well, that's the point. I'm not doing what everybody else does because what they're doing doesn't work, and
Hmm.
what I do works." But they don't like that. That's
Hmm.
you've got to follow narratives and dogma, and you've got to follow
The
the rule.
rules. Yeah.
If you don't follow the rules, somebody's going to throw you under the bus. Usually, a competitor.
Hmm.
You know, nurses are fairly well known for eating their young, and doctors are kind of the same way.
Hmm.
If a doctor, if you're stealing patients from a doctor, they get mad and they figure out a way to get you in trouble.
And you're not even stealing. A lot of the time, these patients come looking for you because they're not getting the help from their doctor. So it's not like you're calling them up and poaching them. So,
Well,
whatever.
I mean, if some woman comes in to see me and says, "I want a second opinion," then she likes my opinion better.
Hmm.
I'm not stealing anybody. I'm just giving her an alternative.
Hmm. Which isn't the whole idea that at the end of the day, the medical industry, because it is an industry, helps people, not just makes money off them.
Yeah. I mean, doctor in Latin means teacher. So
Hmm.
I'm a teacher. I'm
Yeah.
supposed to teach. I'm supposed to teach. So you come see me, you don't know the lingo, maybe you don't know all the words, and you tell me what's wrong with you. And my job is to put all that together and figure out, okay, how do we get her back to her
Balance.
homeostatic, her
Yeah.
homeostasis?
Hmm.
So there's a guy named William Osler. You ever heard of him?
No.
Yeah, he founded Johns Hopkins School of Medicine. And I remember way back at Mizzou when I was in med school, I carried this little thing. It was called the Bedside Companion by William Osler,
The book.
MD.
Hmm.
It was written in 1905, and he had hand drawings in it. And he was kind of famous for sort of, I'm gonna paraphrase what he said. So this is 120 years ago, 25 years ago. He said, "Shut your mouth. The patient is trying to tell you what's wrong with them." And he believed that if doctors would listen to the story,
Hmm.
he said 90% of the time, you already know what's wrong just from listening to what they tell you. They might not have the medical jargon right, but if you be quiet and let them tell the story, he
You get
thought
the
that was
answers. Hmm.
he thought that was the art of medicine. He said if you do a physical exam, that's going to confirm what you already think
Hmm.
from listening to the story. So I'm pretty well famously known for very open-ended questions when I get history. And then I just sit back and let them tell me stories. And eventually, what I'm after is the trauma, the traumatic event that makes a person's health go southward. There's
Hmm.
always a trauma. And it might take me 6 months to get the story out of them, whether that's from they don't think about it or embarrassment. I've had that.
Or
And
they've blocked it out sometimes.
they blocked it out, PTSD type stuff. But eventually, if I work with them and I let them speak and go through it, it sounds like I'm doing psychiatry, but I'm not, or psychology. What I'm doing is letting them come to the realization of when that particular part of their life, everything started going the wrong direction. And so
Hmm.
I'm not equipped to deal with psychological trauma or the psychology of that, but I am equipped to figure out, okay, that's when things started going wrong for you. So how do we get back to the year before that?
Yeah. There's
That
always, I hear it a lot. And back. to corroborate what you're saying, not only do they give us the answers when we do these longer conversations, sometimes the answers become more clear to them as well. Before we even say it, they go, oh, by saying
That.
it out loud, they already know the answers too. But you're right, there's always everything was good until, or it was after this happened that there was always some event, and sometimes they may not know, but there's usually that metaphorical trigger that we would speak of.
Yes, I mean you can watch the light bulb go off. They'll be telling you a story, or you're saying, okay, you know, maybe some directed questions, and all of a sudden they go, oh.
And they just need you to confirm it. They just need you to say, well, you know what I'm hearing or seeing here is blah, blah, blah. And then if there
Right.
is a blood panel or a physical exam, and you can then corroborate what they're experiencing, you can be pretty confident that you're on the right track.
Yes, and you know, we went through the time period during that COVIDian complex where telemedicine was okay everywhere. And I think patients really realized there's no reason for me to go to the doctor's office. And I've always said that. I said I've been doing telehealth consultations around the world since 2008.
Mhm.
I've helped people in Pakistan, China, New what am I saying? Australia, Rome, London,
Ireland.
Canada, Ireland. No, not so many. I don't know if I've had any Irish people, but like all over the world, people will get a hold of me somehow, and we just work it out, just like we're doing here. I don't need to touch them. I can hear the story and figure out, okay, you need to go ask your doctor this, that, and the other, do all that, and see what they say, and they get pushed back
Mhm.
because it didn't fit the narrative.
Yeah, for sure. So, a big part of what you've done over the years and what you're known for is hysterectomies. Now, obviously, with the population in the States and Canada, there's going to be higher numbers in the States annually, 600,000. But Canada, for such a small population, we have between 35,000 and 40,000 women a year getting hysterectomies, and a lot of them are for non-cancerous issues. It's for heavy bleeding and the likes of fibroids, which is going to be a conversation, and what women are taking out a major organ.
Yeah.
So your experience really is in hysterectomy. You've performed a lot of them, that which must have been very interesting. Why do you think still, as we speak today, hysterectomies are so prevalent? They're being offered like candy to women.
Pays well for one, just to be honest. It's
Mm,
easy. Not always. I shouldn't say it's easy. It's not easy, but it's quick. Let's put it that way.
mm,
So in other words, instead of trying to figure out, okay, why is this happening? And for me as a woman, if I was a woman, I would say, okay, let's say that a doctor says, well, if we take your uterus out, everything will get better, and it doesn't.
mhm.
I would be miffed. I would be really like,
Lawsuits, yeah.
no way. You altered my anatomy and told me they would fix all my problems,
Mhm,
and it didn't. So there's hormone, again, the shining protocol, right? So there are very reasonable reasons to do hysterectomy, cancer being one of them. Um, although I could maybe Carol and I could probably have a whole conversation about why that not might not be true.
mhm,
But you know, pardon me, hysterectomy is just like considered sort of a rite of passage. So you started having periods when you were 12, 13, and you do that for, you know, 30 years, and you've had your children. And then, you know, if we take your uterus out, you don't have to put up with that anymore. So my famous question when women would come into me, let's say they were 40, so they got potentially another 10 to 12 to 13 years of having periods. And we kind of fostered the idea that having periods means that you're going to have pregnancies, which is not really true.
Mm.
And they come in and say, I'm tired of these damn periods. Take my uterus out. And my, uh, if I could get them on camera, they would tell you the story.
Mhm.
I would say they'd say, just take my uterus out. And they say, what do you do when your vagina falls out in 20 years?
Mm.
And they'd say, huh?
Yeah.
And I'd say, well, go to a nursing home in whatever town you live in. Just go to the nursing home. This would be violating a boundary, but go in and see how many women have everted vaginas in nursing homes who've had hysterectomies 30 years prior.
Yeah.
And they're laying around in urine, and their vaginas are hanging between their legs. The skin has been keratinized. They're uncomfortable. Blah blah blah. And I said that happens all the time. You just
Mm.
don't hear about
Mm. Or
it. And I
we
guess
don't hear.
you don't hear about it. They probably don't talk about it. Like you go see grandma at the nursing home, she's probably not going to say, "Oh, look, my vagina fell out." It's really annoying. They're not going to bring that up.
Mm. As disgusting as it sounds, I have seen it when I was a teenager. I worked in a nursing home for a couple of years and I would help the nurses and you not to get too like detailed or vulgar, but they with their hands have to push it back in and it is traumatizing.
Yeah, it can be annoying for sure. And then, I mean, think about it, every time you got out of bed to go to the bathroom, you had not prostadential, you had vaginal prolapse.
Mhm.
So most women know that your bladder falls and all that kind of stuff, but there's an end result to that because we are under the force of gravity from Isaac Newton's work. And if you don't have anything holding the top of your vagina in, it's going to succumb to gravity over time. So
Mhm.
that's one issue. And then the other one was, uh, so you mentioned tubals, and a hysterectomy would be a major tubal ligation, correct?
Yeah, well, you're just taking everything out. Yeah.
There's several. Well, even if they left the ovaries, most people are going to sever the fallopian tubes or remove them.
Mhm.
Let's say you spare the ovaries, you keep the ovaries in, but you're either gonna cut the tubes in half, or maybe you actually take the whole tube out. Well, what people don't realize, apparently GYN surgeons don't either, is that 1/3 of the blood supply of the ovary is from an artery that runs underneath the fallopian tube.
Mhm.
So to me, I used to tell women, okay, for tubals or hysterectomy, uh, you need to be prepared that the function of your ovary is going to change because we're going to give the ovary a stroke.
Less
You're
blood flow.
stroking less blood flow. And they'd say, what do you mean? And I'd say, well, think about if I took a hemostat and I went to your carotid artery and I clamped it off and then asked you your phone number and you couldn't remember, that's a stroke.
Mhm.
So same thing with an ovary. You cut the blood supply immediately, clamp, cut, immediate drop in blood flow by 1/3. And then you're expecting these ovaries to continue to function and make the same amount of hormone as prior to having that blood flow, and they can't do it.
Mhm. Yeah.
So you've accelerated dysfunction of the ovary, which happens naturally at 35 to 40 anyway.
Mhm.
So if you're 38 and you're starting to get reduced ovarian function, so your fertility rate has gone down, and then somebody chops your uterus out or ties your tubes, you've just accelerated their aging about 5 to 10 years. And if you take their ovaries out, you've made them 52 years old immediately, like within 30 minutes. You take the ovaries out, they wake up in the recovery room and they're menopausal.
This is where the theory that a woman post hysterectomy shortens her lifespan by 5 to 10 years, right?
True. That is true.
Most women have never heard of that. Most women listening to this now are falling off the chair going, nobody's ever told me this.
Well, of course, and that goes to my big gripe, which is informed consent. So if you're going to alter somebody's physiology and their anatomy, you probably ought to tell them, okay, here's the potential ramifications of doing that. And one of them is reduction in lifespan.
Which is kind of important.
Yeah. So I mean, if I told you, okay, I'm going to do this thing, and you're going to feel you won't be bleeding,
Hmm.
but you're going to die 7 years earlier. What do you want to do?
Is
Who
there
would
another way? I would say, is there something else we could do?
are there alternatives? And
Mm.
that's the informed consent. I mean, my informed consent. Well, let me go backwards. I'll tell you why I got to think that way. Because I'm a man. I don't know what it's like to have a uterus or periods or any of that.
Hmm.
But when I was in early, I think early after I graduated from residency, so I became an academic physician in 1990. And do you remember the show 30 something?
I think so.
You
I
tell me how
mean,
old
I
you are.
may not be. One, I was in Ireland, and two, I was a little bit younger.
And you were younger. So I'm going to say it was 19, and I can find the episode. I've done it. Um, and I want to say it was like 1991. It was an episode where an actress named Patricia Wettig uh, had ovarian cancer.
Okay.
So I can't remember the characters' names,
Hmm.
but she sees a GYN doc who's a female. So so this is early 90s. So even having a female GYN doc was kind of novel. And I don't know if she was an oncologist or whatever. I think an oncologist. So she does a hysterectomy and takes her ovaries out. And Patricia is having all this trouble at home. She gets real emotional, and she's this and that and all that. And she comes back for a post-op visit, like I want to say, seeing her maybe twice a year. So I want to say this was like 6 months, maybe a year after her hysterectomy. And she blasts this doctor. She gets so angry at this gynecologist. And this lady's like, "What are you so angry about?" And she said, you sat right here and told me that doing a hysterectomy would not alter my life in any way. And you lied to me.
Hmm.
And I remember watching that, because I was doing hysterectomies and all that, and it changed my informed consent.
Hmm.
Because what she was mad about was her hormones were all out of whack, and she had ovarian cancer, so she couldn't take them. And she said, "My sex life is obliterated. It's gone. I have no libido. Sex feels different. I can't have a climax like I used to because my parts are gone."
Hmm.
It was impactful to me, and I'm not a girl,
Hmm.
but I was the person that was propagating, okay, we're going to do a hysterectomy. I had not had any of those conversations with anybody in the years I was training, and the first year or two that I was an academic doctor. And so I started doing that. And that's what morphed into a really complete informed consent and alternatives to hysterectomy for me as a surgeon.
That must have been an oh shit moment when you saw that. You're like, I've already done so many of these hysterectomies and not fully informed these women, in a sense, not fully given them the option to have other choices made that,
Right.
like, that again, and oh shit, I've done this kind of thing.
Right. And, everybody I mean, hysterectomies are fun most of the time, not always, but hysterectomies are, it's a skill. I was a vaginal surgeon, and we'll get into the difference between abdominal versus vaginal hysterectomy and maybe laparoscopic hysterectomy. But I was trained by two really, really skillful vaginal surgeons. So my hysterectomy approach was vaginal, and most surgeons, that's not part of their training. I mean, a general surgeon can take your uterus out abdominally,
Hmm.
but if you tell them, "Oh, you got to do it vaginally," they'd be like, "No, no, 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 I'm not doing that. It's quicker to do it and cut somebody open and take it out that way." I go, "Well, of
Hmm.
course it's quicker. I mean, I could probably teach anybody that has decent skills with their hands how to do that. But doing it vaginally is a whole different ball game." So I think what it led to me, and so thinking that these stories and these television shows don't have impact, it did me, and every patient I ever saw after I saw that episode got the benefit of Patricia Wettig as an actress having a come apart with her GYN surgeon about, you altered my life and you didn't tell me that was going to happen.
Mm-hmm.
So what I did was morph that into, okay, we're going to have that conversation about sex and hormones and muscle tone and this and that and the other thing. There's different, like even the climax stuff. I was surprised they said that on a national television show, but women have different triggers for climax, and hers was gone. And for her, it was her cervix, and she didn't have a cervix.
Mm-hmm.
It was gone. So the cervix was her orgasm trigger, and she no longer had that.
And
It
you
was an
already
interesting.
mentioned the bladder as well. So there's high prevalence of incontinence too.
Independent, yeah, there's an independent risk factor for incontinence from women that have had specifically abdominal hysterectomy. That is its own risk factor for bladder control. I bet you never heard that one, have
No.
you? Yeah. A nurse practitioner that I was dating and I did that study and we proved it about 30 years ago, 25 years ago, almost 30 years ago. Women who've had abdominal hysterectomy have a higher risk of bladder incontinence later. I mean, you've got the bladder incontinence from all the different ways that incontinence presents, and you got to work it up to figure out why.
Mm-hmm.
That's an independent risk factor. So we've had that conversation, and then I decided, rather than just say, okay, you've got this, let's take your uterus out. You got a fibroid, let's take your uterus out. I go, okay, let's think of 5 or 6 other things that, we can talk about hysterectomy, but let's talk about these 5 or 6 other things that you can do that won't alter your anatomy, won't alter your physiology, and is less expensive than major surgery and the recovery and the potential risk of death and all that. And then I would say, okay, so let's talk about all these 6 things. And then you tell me what fits your personality and what's satisfactory for you.
Mm-hmm.
Realizing that if you do something that's less invasive, you always have that to fall back on. So, what if you do something simple
Mm-hmm.
and it works and you're fine?
Yeah. At least you've tried other things before Plan B.
Yeah. And you always have plan B in your back pocket.
So what it's my understanding that the majority of women who are getting hysterectomies, they are doing so because they have very heavy, painful bleeds that may go on for long periods of time. Not everyone. Some women will bleed for months at a time. Some women are having short bleeds, but they're just excessively uncomfortable, destroying their lives. And the doctor really, like we've discussed, doesn't give them an option. Just here's a hysterectomy. And women at that stage, they're so desperate that they don't even care. They're like, this is ruining my life. I can't leave the house. I'm calling in sick to work. And again, this affects their marriage, their sexual health, their even desire to be intimate. So I can understand why women are making these choices. But why do you think this is happening? Like, what are the main reasons that you've seen in your practice over the years that women are choosing to have hysterectomy?
Well, I think it's almost like I said, a rite of passage. It's just become, I mean, it's gotten so much safer, even in my lifetime career, to have major surgery. I mean, people think about dying in surgery, and I go, okay, so let's talk about risks. So your risk of dying in surgery is like 1 in 375,000. It's there. It's pretty rare, but it's there. I mean, your risk of being killed in your car today is 1 in 6,200. So it's way safer to have surgery than it is to drive your car.
Mhm.
So it's almost like women consider that a right. Like I said, it's a rite of passage. Well, at what age did you have your hysterectomy? It's like a thing. Everybody does it. That's kind of how it is. And like I said, it's an easy decision to make. You've got horrible periods. They hurt. They're crampy. Blah blah blah. And the doctor goes, "Well, we can take your uterus out. Be done. You're done forever."
Except
That's
you're
an easy,
not.
except you're not. But your decision is pretty easy. It fixes one thing and maybe gives you some other issues to deal with for the rest of your life. Um, So I think it's almost like just considered. I mean, you mentioned vaccines. You mentioned vaccines. Everybody just gets their vaccines because you're told to get your vaccines, right? Nobody thinks about it.
Hmm.
When's the last time you had an informed consent discussion with your doctor before you got a vaccine?
So there's an element of trust there, which means if a
Yeah.
doctor offers you a hysterectomy, some women are not even questioning it because of that element of trust.
Well, yeah, and I think the trust issue has come to a head, at
Hmm.
least in this country, because it used to be your doctor. If you were a physician, that was one of the more highly trusted professions, maybe in the world, but definitely in the United States. And after that COVID thing,
Mm.
that's gone. I mean, the trust, I trust my doctor has fallen to like, I want to say 30%,
Kind of
maybe
like
even
how we
more.
trust our politicians.
Yeah, well, I've never trusted a politician. I'm a Mark Twain guy.
Yeah.
I live in Missouri. Mark Twain was griping about politicians back in the 1870s.
Yeah, well, he wasn't wrong.
He
Even the
was
doctors back then.
smart little guy for a guy from Hannibal, Missouri. But yeah,
So
so
we've mentioned the heavy bleeding, and obviously the prevalence of hysterectomies is more so done in women in perimenopause, where
yeah.
bleeding seems to become excessive for a lot of women. Why is that? Do you know why I mean, Dr. Geraldine Pryor, I don't know if you're aware of her. She's a doctor out at the University of BC here. She founded the Center for Menstrual and Ovulation Research. So she's had a lot of publications specifically on women's health and the use of progesterone. But one thing she is very vocal about is that women have their highest levels of estrogen during perimenopause. And that's why she is so outspoken about the use of progesterone for most perimenopause symptoms.
Yeah, she's alluding to what's called estrogen dominance. And if you get a mismatch in estrogen and progesterone, and the reason that you're not as fertile as you get past 38, let's say, years old, is that your corpus luteum does not make as progesterone as efficiently. And if you are not making enough progesterone in early pregnancy, you will miscarry. So if you're pregnant, you don't make enough progesterone, you don't carry your baby. If you're not going to be pregnant and you're perimenopausal and your progesterone is mismatched, you're going to get screwy periods.
Mhm.
Very unpredictable. So could be heavier, could be lighter, could be skippy. They could be skipping. You could bleed twice a month. You could bleed for 3 days and then 3 days off, 3 days on, 3 days off, 3 days off. And that's that mismatch. What's the wastebasket term is ovarian dysfunction. If you think of the English of that, that doesn't mean anything.
Mhm.
Uh, so ovarian dysfunction, that's, anytime the ovary's not functioning exactly the way it should, that's ovarian dysfunction, which could potentially be diagnosed in every woman I've ever met. I mean, if you've ever skipped a period, you have ovarian dysfunction.
Oh, for sure. Yeah.
See what I mean? So the estrogen dominance is the issue. I'm not going to say they make more estrogen perimenopausal. They just make less progesterone,
Hmm.
and that gives you this.
The ratio hands.
It's all. And then even more important is the fact that the most proliferative hormone made from women's ovaries, and it's 1,000 times higher than estrogen, is testosterone. So half of the testosterone in women come from their ovaries, and when they become dysfunctional, they start getting low T symptoms just like men.
Mm.
So it's kind of unfortunate that testosterone is labeled as a male hormone and estrogen's a female hormone, because I have estrogen and you have testosterone. Does that make you me more girly and you more manly? No,
No.
it's just, and you make more testosterone. I always say per capita. Women make more testosterone per capita than men do
Hmm.
by far.
Oh, yeah.
That gets blown off completely. Oh, well, you don't know testosterone. What, you want to get whiskers? You're going to turn into a guy. And I'm like, I've been giving women testosterone for almost 40 years. None of them have turned into men. You just got to know what you're doing. but it's an important hormone issue that is completely ignored for most women. And Carol and I have appeared on a webinar with a woman named Angela DeRosa, Dr. DeRosa, through Belmar Pharmacy, who bought the pharmacy that Carol worked for, how I met her.
Hmm.
And Angela DeRosa talks about the gender bias in approaching women's hormones. So
Hmm.
she's a younger version of me, and she's a woman.
It's a slow but changing process, the utilization and understanding and bias of hormones, what
Yeah,
we are willing to give women and what we're willing to give men. But that's a whole other rabbit hole as well that we could probably both agree that big pharma is involved in too and
yeah,
has their say there. So we've got the heavy bleeding in women. Obviously, their lives are being ruined. We can understand why they'd want to give up hysterectomy. When I was mentioning the stats, especially for Canada, I would assume it's the same for the States, that women here are also getting diagnosed with fibroids, and
yeah,
that's a viable kind of excuse to give someone a hysterectomy, even though Dr. Pryor, who I just mentioned to you a minute ago, mentions that fibroids don't even bleed because they don't have a blood flow. So how is that contributing to your heavy bleeding issues?
yeah. That's interesting. She says that because when you operate on fibroids, there is no blood supply. You can carve out a fibroid and lose very little blood. I've done it, I don't know how many times. So here's the thing that I will say that I'll piggyback onto her saying they don't bleed. If you look with transvaginal ultrasound, and I was famous for doing an ultrasound on every woman every year. They had a pap smear. I would do a vaginal ultrasound, not charge for it, take a picture, stick it in the chart. So I could see development of stuff from year to year. 75% of those women have fibroids.
Mm-hmm.
So, and that is held up by the data. There's a woman that wrote a book called Sex, Lies, and Uterine Fibroids, probably 20 years ago, who got really angry because her gynecologist took her uterus out because she had fibroids. And
Which
she
is
had,
what I'm sure there's some women listening to this now going, hold on, I got my uterus removed because I had fibroids.
yes, that's the number one pathologic diagnosis on a hysterectomy specimen. And what I'm telling you is if I take your uterus out and send it to a pathologist, they're going to look at the thing and they're going to say, oh, well, she has these fibroids. So then you can, as the surgeon, you can come back and say, well, we just caught it in time. You were getting fibroids and this and that and the other thing. And that, so if 75% of women have fibroids, to me, it would be abnormal not to have a fibroid.
Yeah.
So the fact that somebody has a fibroid was irrelevant to me. I'm not gonna say I didn't care. I'd say that has nothing to do
That's
with
not
the
enough
appearance.
reason to do it. Yeah.
That's not just because you have a fibroid, we're not taking your uterus out. That's what stupid gynecologists do.
Mm. What
The ones that
about the likes of then endometriosis or adenomyosis? Is that reason enough, or are there other solutions?
sure can be. There are solutions, and I was part of a multi-centered randomized trial back in 1990 where we showed and this was a pharmaceutical based study. So I actually did a pharmaceutical study on leuprolide acetate, which you would know as Lupron.
Mhm.
There's another one called gonadorelin. And we showed that because back then, if you had endometriosis and you didn't want to have a hysterectomy, so you go to the doctor and say, well, I've got this endometriosis, blah, blah. I don't want to have major surgery. And they'd say, well, we're going to put you on a birth control pill. Well, endometriosis is an estrogen liker. It's like feeding the endometriosis,
Yeah.
kind of like fibroids. Fibroids are estrogen dependent. It's the reason endometriosis and fibroid is more common as you get perimenopausal because you have that progesterone drop and estrogen dominance.
I
So
believe in,
really,
I'm sorry to interrupt, but I believe in your conversation with Carol, you said it was either fibroids or endometriosis, eat estrogen for lunch.
Yes, that is true. It does. So if you're giving a woman with endometriosis a big, huge, powerful ethinyl estradiol birth control pill, it's like a guarantee that it's the endometriosis is probably going to get worse.
And that's the same with the IUD, right?
I'm not going to say the IUD. I'm kind of I mean, if you go back to the copper T380 and the Lippes loop, I was a big fan of IUDs.
Mm.
And when we were told I was a resident when we were told every woman with an IUD, you got to take it out of them. And I had women that would say, if you take my IUD out, I'm going to punch you in the mouth.
So you were forced to like them.
And I would say,
It was fear.
yeah. They'd say, well, you're not taking my Lippes loop out. I've had it for 20 years and I don't want to start taking pills and shots and all that.
But the
So
problem is, I'm sorry again,
some
apart
of
from the
them,
copper IUD, the problem is with the other ones, they have more estrogenic activity. Like none of them contain bioidentical progesterone.
no, they don't. Yeah, they've got a synthetic progestin, and that's an important distinction because progestin and progesterone are two totally different things, and most women don't get that. Most doctors don't get that.
Mhm.
They'll say, "Oh, take this progesterone," and I'd be like, "That's not a progesterone at all. It's a chemically altered progesterone molecule. It is a progestin. Has completely different, more powerful, horrifying side effects.
Mhm.
Way
It's
worse."
unfortunate.
So for huh?
I was going to say, I spoke to a doctor recently. Lovely woman, like helping a lot of women, but she told me that she wasn't aware of any IUDs that had estrogenic activity, that all IUDs have progesterone in it. And I corrected her in a respectful way, but I was like, man, she's out there. She's making a difference. Like she is helping people, but she doesn't even understand this, which is slightly concerning.
Well, hormones are one of those things that when I was a medical student, I ignored them. The first 2 years of my residency, I ignored them. I thought this is, nobody needs to know all that. And then I had a mentor who was an IVF doctor, and she taught me hormones. She gave me a textbook to read, and all we dealt with was hormones, which led into my foray into treating perimenopausal women who didn't want to get pregnant with hormones because I realized the women who were infertile, if we would maximize, well, not maximize, optimize their hormones, they felt better and younger.
Mhm.
So in my little brain, I thought, well, what would happen if you did that to a 42-year-old and didn't get her pregnant or didn't try to get her pregnant? So I did that. And these 42-year-old and 43 and 38 and 47-year-old women were like yippee skippy. I feel like I did when I was 28 years old. And I go, that's the power of hormones. So that was the light bulb for me.
Mhm.
So the hormone thing for most doctors is irrelevant. It's annoying. They don't know anything about it. And what I always tell women is if you see a doctor and they don't know what they're doing with hormones, find a doctor that does know what to do with your hormones because you can mess somebody up really bad with if you don't know what you're doing.
So
So,
you mentioned that endometriosis is a viable reason to have a hysterectomy, but what if someone has microscopic endometriosis? Then they've got their uterus removed, but they're still having the same
yes,
symptoms
right. Because the only cure for endometriosis is menopause.
where the
So if you're
estrogen has slowed down.
where you've just eliminated estradiol production from the ovary. You've taken the ovaries out, you've taken everything out. That's the only cure for endometriosis. So our study in 1990 was if we put people in reversible menopause,
Hmm.
Lupron, so if we operate, so the study was set up that I had to operate on somebody. If I found endometriosis, I didn't do anything. And I told the patients, I'm looking for endometriosis. If you haven't, I'm going to show you this study and see if you want to participate. They either took a fake shot and a birth control pill, Low or they took a fake birth control pill and a Lupron shot. It was double blinded, randomized. I didn't know who was getting what, although I could figure it out. And then 6 months of that, we would go back in and operate. We took pictures. Here's before, here's after. And then I could do whatever I wanted surgically, other than hysterectomy, to help their endometriosis. And we found that we eradicated symptomatic endometriosis in 98% of women who were on Lupron, and we had improvement on only 30% of women on a birth control pill. And what I learned from doing that and doing that kind of surgery is if you're going to be conservative into your approach of endometriosis, you have to be aggressive without removing parts, and you have to actually take scissors and cut that tissue out, and you have to have a wide margin, kind of like if you were taking cancer out.
Because it
So
spreads.
yeah, endometriosis is just like cancer. It just doesn't kill you, but it spreads, it metastasizes. There have been case reports of endometriosis in women's noses where they have a nasal they have a nosebleed every time they menstruate. I have found it in belly buttons of laparoscopic scars. I found endometriosis in women's cesarean section scars. It's been found in the liver. It's found, all through the abdominal cavity. I'm not sure brains, probably not brains.
I've heard some other doctors say they found endometrial tissue like in the brain. But is this also why a lot of women will have the symptoms of endometriosis, but they won't get a diagnosis because it is so small, the doctors are
Yes,
not looking properly, hence the name microscopic. So just because your doctor screened you for it, but you didn't get a diagnosis, does not mean you don't have endometriosis.
that's right. And if you're going to diagnose it, you have to take a pair of scissors and pickups and cut some tissue out and send it to a pathologist and say, does this have endometriosis in it?
But surely
That's
you'd
the
have to
only
do that in multiple tissue
would.
biopsies.
Yeah, there was a guy, there was a laparoscopic guru from back 25 years ago. He would always say, I biopsy everywhere. If I think endometriosis, I start taking little biopsies.
Ugh,
And
that
what
must
he's
have
trying
been
to
very
do is,
painful.
no, I mean, you're asleep.
Mm.
The laparoscopic, he's done with a laparoscopic approach. But if he found it, then he knew what he was dealing with. Otherwise, it was kind of an educational guess. And
Mm.
what's the number one symptom of endometriosis? Do you know? It's
It's
not
a
pain. It's not bleeding. It's not painful intercourse.
fatigue is one.
Yeah, but this one trumps them all.
Well, apart from the systemic inflammation and the cycle issues, back issues would be one that a lot of my clients experience. Gut
Yeah,
issues.
lots of symptoms. The number one symptom is infertility. So difficulty achieving pregnancy. And so I used to tell women when they come in, they'd say, well, I've been trying to get pregnant for 18 months or 2 years and I can't get pregnant. I'd say, if I would say you have endometriosis, I would be right half the time.
Hmm.
So
So
that's the most common symptom. Most people know about cramps, painful intercourse, and weird bleeding. But there's a whole plethora of stuff that endometriosis lends itself into causing trouble.
Well, as we start to wrap up now, Dr. Tracy,
Yeah.
I'm curious because we've spoken a lot about the women's side of things, but do you have an opinion then? Because when you mentioned the blood flow with tubal ligation, it would be the same idea with vasectomy for men, no?
From a man, I'll tell you my story. I had a vasectomy at 38. It dropped my sex drive and libido immediately, which makes no sense. I've had this argument with urology friends of mine. They're like, it doesn't have anything to do with your testosterone. And I said, I was 38 years old. I'm telling you, I had a vasectomy bilateral. Within a month, I started having erectile dysfunction, loss of libido, fatigue, low T symptoms, all that. So I said, that sounds all, fine and good that you say you're not interrupting something, but you're assuming that every surgeon that does a vasectomy is clean and pure and only gets the vas deferens, doesn't interrupt any blood supply at all. And I said, I'm going to guess that that's not true because I've seen very skillful surgeons who are licensed and practicing, and I've seen surgeons that were butchers that are licensed and practicing.
Mm. Yeah, well, that's the case, isn't it? You can qualify at the bottom of your class and still get the title doctor.
Yeah, I mean, I remember watching the doctor operate one many years ago, and I'm looking at this guy going, he has the worst surgical skills I've ever seen, and everybody loved him. Everybody thought he was a great doctor, and he was a nice guy, and he knew what he was doing. He was just a terrible surgeon. He
Mm.
was I mean, he was like a hack.
But he had good bedside manner and
Yeah, good bedside
knowledge, just
manner and
not
all
the
that.
skills.
And he would have surgical complications. Nobody ever sued him. He did stupid stuff in the OR that caused trouble. Nobody ever sued him because he was a nice guy. And I'm like, well, yeah, he's a nice guy, but he's just not a very good surgeon.
Mm.
I don't
Yeah.
know why. I mean, after a time, and he was older than me, so I'm sure he's retired now. But my guess, I mean, usually you do stuff over and over again, you just get
Get
better at
better.
it. And this guy didn't. I'm like, oh my gosh, he was like a first year resident that you just hand him a scalpel and say, here, cut that. And he would do it and cause trouble.
Oh, so we're gonna just talk about some other options to hysterectomy. But one thing we've already mentioned is progesterone. Myself, yourself, Carol, we all agree
Yeah,
progesterone is an amazing tool for women. But one thing that annoys me a lot, and I hear it from my clients that their gynecologist told them whenever they ask for hormones, oh no, you don't need progesterone because you don't have a uterus anymore. And I just want to pull my hair out when I hear that.
I agree. That would be like, yeah, that would be like, I'm trying to think of a good analogy. Let's say that that'd be like taking somebody's spleen out and saying, well, you don't need any more lymphocytes or any lymphatic drainage. I mean, it's dumb.
Yeah.
Progesterone is part of the biochemical pathway. And Carol was, I mean, she wrote an article about progesterone for men about 6 months ago.
Mhm.
And Carol's progesterone, I remember we were in that webinar with Angela DeRosa, and somebody asked Carol, uh, what would be your recommended dose for progesterone for a woman, um, just a routine dose? And Carol said something like 2,500 milligrams. And most people are on 100 or 200.
You're like,
And she quotes this lady from the 70s who routinely gave 600.
Katarina
And the most
Dalton. Yeah.
her. And so and I didn't even know who that was. That's why I always say Carol's way smarter than me. She just doesn't have the same background as me, but she's much more brilliant than me. And she says stuff, and I'm like, what? Where'd you get that? And she proceeds to prove what she just said.
Yeah, yeah. Katarina Dalton was the doctor who coined the term PMS. And then
Okay.
for us, it would be Dr. Geraldine Pryor up here, who a lot
Yeah.
of doctors here will have heard from her. But if you can show some of her research and put up an argument that she recommends a minimum of 300 milligrams of
Yeah.
bioidentical progesterone. In Canada, it's hard to get more than 200, but then you can kind of substitute or supplement with creams and other stuff yourself to bring up your dose. But most women would never consider that. And didn't you have a story about some woman with severe PMDD headaches and she used progesterone and got complete relief?
Yes, I learned that from a neurologist. So this neurologist had a practice in Springfield, Missouri called the Headache Center. And she and I were we were out for lunch or something, doing something. And we got talking about all this stuff. And I said, do you think progesterone causes headaches? And she said, or lack of progesterone causes headaches. And she goes, absolutely. I said, migraines? She said, yeah, absolutely. She said, I see lots of women that have luteal phase progesterone deficiency or suboptimal um, levels of progesterone. I put them on progesterone and I just bump it up until the headaches go away.
Which
I
again
learned
is
that.
a lot more though than most women are being
Yeah.
offered.
Well, I mean, she would do it correctly. She would start and say, okay, we're going to start low and we're going to go up and we're going to measure levels. And then we're going to figure out, okay, this level of progesterone keeps her from having migraines. I learned
Mm.
that from a brain doctor.
There is research around low progesterone levels for the likes of syncope and epilepsy too that often do not get recognized at all. But I would argue that a lot of this progesterone requirement for migraines is back to what we're saying, the ratio that these women have massive amounts of estrogen but no progesterone to offset it either. I think it's a really important discussion to discuss estrogen in chronic migraines.
I agree. And
Mm.
these women will ask, I mean, they'll go to their doctor and say, well, I think I need progesterone. No, you don't. You had a hysterectomy. That's stupid. That's dumb. You're just wasting your time. And you want to ask these doctors, have you actually read or delved into this at all? Or are you just doing the narrative?
But
They're
then they
doing
get
the
angry
narrative.
with you and they say, well, if you're not going to trust me, go somewhere else. Okay.
Yeah, they do. They do. Okay. Yeah.
Yeah. But
Yeah.
progesterone is in every tissue of the body. Like it would
Yeah.
make no sense that they don't even know that. Like I'm not a doctor and I know the basics. So just because
Right.
the uterus is gone, how does that mean I don't need progesterone if I utilize it and have receptors all over my body?
All over your body. That's right. Same with testosterone.
Yeah.
I mean, even bones have testosterone receptors.
Well,
So,
yeah.
I could make. There's a lady I met from Boca Raton, Florida. She's a GYN doctor. No matter what you come in to see her for, and she's talked about this. She gave a talk for an hour.
Hmm.
No matter what a woman came in to see her for, she put them on testosterone. That's all she ever used. And she goes, everybody gets better. I put women on testosterone, everything goes away, everything gets better.
Mm. It's
And I
starting
thought, well,
to get more conversation now, testosterone is. Progesterone's had its limelight, and now you can see testosterone starting to come in. Okay, well, let's just give some women, if you wouldn't mind, what are their other options? I cut you off because that's what I do. We talked about progesterone. So a woman is having all these issues from what we spoke about, the heavy bleeding, the endometriosis. What are some other options you're giving them first before our plan B of hysterectomy?
well, I mean, we talked about progesterone, hormone optimization, and all that. Eating correctly, getting rid of cortisol excess, getting rid of body fat that's making too much estrone, getting control of insulin resistance. That would be the very, very eat and lifestyle approach. But also, you've just got like endometriosis. You can do extensive conservative surgery for endometriosis. You can do endometrial ablations. The first ones I did were called hydrothermal ablation with hot water, and I did them in the office. And then they've got the electrical ones, and they did rollerball. The first thing they would do was hysteroscopic rollerball back in the 90s, where they would go in there and just burn out the functional layer of the endometrium
Mm,
and leave the basement membrane. And that took some dexterity doing that. And then they came up with I think the hydrothermal ablation from Boston Scientific came out when I was at the ACOG national meeting in 1996 in Boston. So I started doing those.
mm,
um, and then for endometriosis, that protocol I did with Lupron, add back estrogen. I had some women on endometriosis, sorry, with endometriosis that were 46, 47, and I would put them on Lupron and add back estrogen, and we kept them on it until they actually went into menopause. So 5, 6 years. They just didn't want to have surgery. Or they'd come to me because they said, well, every doctor just wants to hack my uterus out. What are my options? So I said, well, this is a big one. It would take some doing and cost some money, but we could do that. And so I had women that would do that.
mhm,
Birth control pills, not so much, although, and I don't like this drug, but I would use it in that situation. If somebody was bleeding heavily and it was driving them insane, if you put them on Depo-Provera, the full shot, they'll quit bleeding. It's like doing a huge DNC
mhm.
all the time. The problem is you got to put up with the side effects because it's the synthetic progestin.
Hmm. Lots
But
of side effects from the
yeah,
depot shot. There's a whole conversation around that.
whole different one. But that's an option. If you
Hmm.
talk to a woman and say, hey, I could put you on Depo-Provera for the next 10 years, you wouldn't have a period after the first 6 months. So that's one.
Are you concerned that, well, I didn't ask you this already, but it's always something I have concern about that if you stop a woman having a period, where is all this endometriosis building up, or not endometriosis, estrogen that's building up going to if we're not getting it out? Are you concerned we might have a bigger problem down the line?
Oh, potentially, but I think Depo-Provera and Lupron. So Lupron puts you in menopause. I mean, everything just gets shut down, and it's reversible. So you stop the Lupron, and everything wakes up. Depo-Provera for 15% of women, which is I would never use Depo-Provera in teenage girls for birth control because 15% of them will never ovulate the rest of their lives. I'm sure they haven't heard that informed consent either. But Depo-Provera is actually stronger and more efficient than a tubal for birth control. That's how
Okay.
powerful it is.
Yeah.
And that's why there's so many side effects.
Hmm.
The Depo-Provera was not FDA approved for birth control until during my career, and it was used all over the world for birth control.
This is why informed consent is so important.
It is. Now, fibroids, most of the time, even on big ones, as a matter of fact, I saved a woman's uterus from New Jersey last year who everybody was trying to get her to take her uterus out. She was 50, and they're like, hey, you're 50, you don't need it, you're not going to have kids and all that. And she goes, yeah, but it's my uterus. So
It's my
what?
body, yeah.
What you want to carve parts of me out because I got fibroids? And she had 3 fibroids. And she called me. She got a hold of me, and I said, "What do you think?" I said, "Well, send me your films." I looked and all that, and I said, "Okay, one's a 9 centimeter fibroid." I said, "In your mind, how big is that?" Because in an American's mind, 9 centimeter fibroids like this, and it's like this,
Still pretty big though.
but not really. That's not very big at all. I mean, you got a uterus that's say like this big, and if I put a fibroid that's the size of a big marble on it, that's about 8 centimeters. And so she said, if you were still practicing and I came to you, what would you do? And I said, well, you don't want your uterus out, so I would do a myomectomy,
Hmm.
and I would do it with a laparoscope or a robot. And she goes, how's that work? And I said, it's very simple. It's spooky when you first learn how to do it, but I had a surgeon show me how to do it. And there's an approach to a myomectomy where you just open the fibroid and you peel it out like that. You just keep cutting it in half and it just peels out. So most doctors won't do it because they think, oh, you're going to bleed to death. There'll be a horrible bleeding. And I go, there's no blood. There's one blood supply to a fibroid, and it's usually at the base.
Mm.
So you can open the fibroid, you just bivalve it and keep opening it. You get to the base and you put a
Pull it out.
clamp in there, and you pull it out and put a stitch in the vessel, and then close the uterus. You're done. I
Sounds
did it.
like a very delicate procedure though. No wonder they don't want to do it.
It takes time.
Yeah.
I mean, it does take time. Have I seen fibroids that I've started doing a myomectomy and had to convert to a hysterectomy? Yes. So my co-surgeon and I started on a fibroid on a woman who looked pregnant at term. So it was like this. It was
Whoa.
huge, big. And we started working on it, and we couldn't do it. And we were using the robot. And it took us, and we finally gave up after 7 hours. We worked on her 7 hours before we said, okay, we can't do it. We're just going to take her uterus out. And we still did it with the robot. So she didn't have some big, huge incision, went up and down. We did, we had to like cut things into pieces and then pull them out through the vagina.
Ugh. The poor woman. But you did try to save the uterus at least.
We tried because she wanted to. And I said, you got to go into this thinking because this thing's big. And if we get into a bleeding thing at the vessel and all that, we might have to convert it. We might even have to open you up and cut you from your xiphoid down to your pubic bone. You wake up with this huge incision. but we'll give it a shot and see what happens.
Mhm.
And we didn't get the fibroid. We took her uterus, but we didn't have to open her up and scar her for life.
You chose the lesser evil, I suppose. So kudos to you
So
for trying.
that was one, yeah, that was one of my favorite things to do. Is women would say, "I want an opinion. Can you not take my uterus out? I have this fibroid," and I go, "Absolutely. Let's give it a shot. The worst that can happen is I have to take your uterus out, which your other nitwit doctors told you that's your only option, and that's not true."
Hmm. So if we're doing all these other approaches before hysterectomy, the diet, the lifestyle, maybe some progesterone in whatever form,
Yeah.
usually if I'm working with a client and they tell me, look, I'm looking at a hysterectomy for the summer or next fall, I'll say, okay, well, this is what we can do. And I'm pretty confident we'll see improvements, but we're looking at least 6 months. You have to give it time. It's not going to be 3 weeks and all your issues are fixed. What kind of time frame are you looking at?
Same.
Yeah.
Yeah, same. And Americans don't like that.
Who
So it's
does?
kind of like the 80-20 rule, you know. So 20% of people will say, okay, I'm committed to do that. 80% just want the quick fix. But 20% of all the women that have to deal with this, there's people like me. I'm not the only surgeon that thinks this way.
Hmm.
Uh, so the lady in New Jersey, I just scarfed around New Jersey and I found a member of the American Association of Gynecologic Laparoscopists and a robot trained surgeon. And I called this GYN doc and I said, I got this lady in New Jersey. Everybody wants to hack her uterus out and she wants a myomectomy. You willing to give it a shot? And she goes, absolutely, send her in.
Good, good.
So she had surgery, had her myomectomy, and continued to deliver her life.
That's what it is. Teamwork. You need to have a good team that's going to advocate for you when nobody's listening to you.
Right. So
Well,
that's kind of
Dr.
what I do
Treacy,
now. I find clients that need doctors like I used to be, and I and
connect
I'm
them.
I'm the intermediary. I'm a professional medical student.
Good. That's what we need. So, Dr. Tracy, we've covered a lot. This has been awesome. I have more questions, but we can't keep going. I know you want to keep going, but we can't.
Yeah, but we can do several of these if you want.
I really would like to do one on HPV next. That's a huge one. But I'm going to let you go for today because we both have busy schedules. You are a wealth of knowledge. You have your conversation with Carol, which I'll link up. You have your website. Can you just direct people on where to go?
Yeah, I mean, my business is called Health Without Risk, which is exactly what we do. Health without risk.
And your
So
YouTube channel is called that too, isn't it?
I'm all over social media, TikTok, Facebook, Instagram. It's all Health Without Risk. The website is www.healthwithoutrisk.com. So I thought, well, I'll just use, and I like that term. I like that name. I think it makes sense. It says everything I'm talking about, health. And so my tagline is health reimagined, risk removed.
Good. And informed consent.
And informed consent. Yeah, that's
Yeah.
too much to say. But yeah, it's
So
health without risk everywhere. You look except the X uh, app. The X platform is under my name.
when I heard that you were on TikTok, I was like, no, TikTok got another one. I have not succumbed to TikTok yet, and I have no intentions to.
Well, I didn't think I would, but it made me semi-famous. And I had
Hmm.
a friend of mine who was she is a physical fitness and a nutritional coach, and she has 12 certifications. And she talked to me and she said, Bryan, you got to be on TikTok. You'd be great. I watched it. It was a bunch of young ladies twerking and shaking their heinies. And I go, well, that's great. I don't mind looking at women doing that. But I said, what's that got to do with a 60-year-old guy? And she goes, I'm telling you, it's the fastest growing business platform in the world. And so one day, after about 6 months, I just turned my camera on and did a video, and it blew up.
Yeah. Do you remember
Uh,
what that video was about?
why I left medicine.
Oh.
It's the first one I ever did. Why I left medical practice, and I just told the story for about 3 minutes, and that got 680,000 views in my first video.
Cool.
And it's kind of made me somewhat famous.
Hmm.
My biggest video was how to get rid of yeast infections and maintain vaginal pH. And I guarantee you, Carol Peterson knows how to do that.
Yes, she does.
So I taught women
There's
how to.
nothing she doesn't know what to do.
I taught women vaginal hygiene, and I had a lot of women say, "My grandmother taught me that 30 years ago." And you go, "See,
Well, they were
grandma
onto
knows,
something.
grandma knows some stuff."
Mm. I suppose we could tie that into a HPV conversation for sure, vaginal health and pH.
Absolutely, for sure.
Until next time, Brian, thank
All
you for
right,
your time.
you too. Stay in touch.